The debate today is going to be, this House believes that technology is a way forward for patient safety. So in history, we've had some topical debates, we've had some great debates, and we've had some controversial debates. This one promises to be a combination of all three. For the motion, we have Dominic King, who is a general surgical registrar and clinical lecturer at the Department of Surgery. His PhD is in behavioural economics. He's also the clinical lead of the Helix Centre that you heard about earlier, and the theme lead for the design and technology theme of the CPSSQ, as well as being the co-author of the influential Cabinet Mindspace report. Against the motion, we had Jed Murtagh, who is a medical sociologist by background, but with a PhD on doctor-patient communication. He's currently a senior lecturer in communication at the Department of Surgery and course lead for the Medical Undergraduate Clinical Communication Programme. So before we start, I think we should start in the traditional way, and let's have a vote now. So, all those who believe, this House believes that technology is a way forward for improving patient safety, could you put your hands up if you are for the motion? Yeah, okay, all those against? Maybe 50-50, maybe a bit more on the against. And all those on the fence or undecided? Okay, so these are the three that you have to convince. Right, let's kick off. So the way we're going to do it is they're going to have 7 minutes each, followed by 7 minutes of questions from the floor, and then we'll take a re-vote at the end. So to start, Dominic?
I was hoping in this esteemed centre of technology, Imperial College, that I'd have more people already on my side, but that doesn't appear to be the case, so I will try my best to persuade you. So just to start with what I think is an interesting perspective on the issue of patient safety, and that's the difference between intentions and behaviour. Now, our behaviour is often out of keeping of our underlying intentions. So most of us would like to go to the gym a bit more, most of us would like to eat more healthily, save a bit of money at the end of the month, but very often our behaviour is completely out of keeping with that intention. Now, the same paradigm can be kind of discussed in terms of patient safety. I don't think we'll find a clinician here that doesn't want to or doesn't intend to offer safe and high quality healthcare. But very often the decisions we make on a day-to-day basis don't lead to that. And I think we just need to look at the numbers for that, for me to prove my case in relation to that. So this is just over a 3 or 4 month period, 2014, data from NHS England on NIVR events. So despite all the attention given to these areas, despite all the guidelines, all the training, the sanctions, checklists, a couple of times every week in the NHS in England, people are having swabs left in them or having the wrong organ or limb operated on. Now, what accounts for these aberrations? None of us intend to cause this harm, but what accounts for these aberrations? Well, from a kind of behavioural perspective, there's 4 or 5 decades of research across the behavioural sciences that demonstrate we are not these rational supercomputers, and humans are actually predictably irrational and many times are prone to errors that have significant consequences. In a healthcare context, clinicians are humans. We make the same mistakes, the same reasons why we fail to complete our tax form correctly or not pay our credit card at the end of the month are the same reasons why we fill a prescription in wrongly or forget to action an important test result. And actually, probably more so in a clinical environment. It's hectic, it's chaotic. Now this sum here, most of you, by the time I finish this sentence, will have worked this out. Now if I put you in the context of a busy ward round, noisy, lots of people competing for attention, you'll be much more likely to get this wrong. And you can see the analogy of this to kind of prescription errors or similar. So most people in this room may argue that training and education is the way forward, and Jed may also say this. I'm going to say that I don't think that's the case. I think you look at systematic reviews in lots of areas of, related to patient safety, prescribing, hand hygiene, and education and training has little to no added benefit in many circumstances. So that brings me on to the technology aspect of this talk. What role does technology have in patient safety? a lot, I would say. Now, technology has transformed how we investigate and treat disease. But we are not just way back, we are decades behind other industries who have really improved their safety profiles through the more effective use of technology. So I bought my first car 10 years ago, and it was not until 3 or 4 months ago when it started making lots of noises and I have a new baby that my wife said, we have to get a new car. So it is incredible how the automobile industry has transformed using technology. So as standard now, there's lots of assistive technologies that prevent error. Okay, so I drive out of a lane, my car beeps, someone comes close to me behind, my car beeps, my car brakes automatically. The automobile industry recognizes that humans err, and they design things and produce technology to try and prevent problems happening. Now, I would say I'm not here saying that I want to see robots replace clinicians. I think we should be taking a compassionate, human-centered approach to medicine. But I also think we should be providing a safety blanket, a bit like the car, to stop me causing problems that will affect my patients and their outcomes. So there's a number of areas where technology is transforming or has the potential to transform outcomes. And I'm just going to touch on a few of them. And many of you will have kind of ideas about some of these. Decision support. Now, we would have no errors in NHS if we all followed the protocols and guidelines that are set for us. It is incredibly difficult and I think implausible to presume that every clinician can keep up to date with the latest guidelines. We're moving towards electronic medical records. You know, all of us that work at Imperial have seen these changes over the last few months. Now, these aren't just something that, you know, a static information resource. These platforms now have a level of sophistication that can identify trends. They can pick up errors. They can warn you that there's a test result that you haven't checked. And so these things can have a really dramatic impact on us managing our patients better. Medication safety. There's a whole unit in Imperial that look at this. Bryony spends most of her days trying to find a solution to stop us prescribers causing harm to our patients. Now, I'm not negating the benefit of extra training and education. I'm certainly not, and it's important that medical students and junior doctors have more training in relation to this. But there are platforms coming through, and I know some people will say, oh, well, electronic prescribing may cause harm or problems, but there are advances on a daily, weekly, monthly basis in these platforms that if I enter a medication that someone has an allergy to, if I enter a dose that is obviously incorrect, if I enter a drug where there's a possible interaction with another drug, this will flag things up. I cannot be expected to know the whole British National Formulary, but these platforms can. Improving communication. Now, I tested this, you may have seen, just before I came on, and the video doesn't work, so I think I've lost my argument. But, I mean, it's maybe it worked. I don't think it is. It's incredible. Anyone that doubts how far behind we are, we still use bleeps. We still use fax machines as a standard method of communication. So what we've created here, Max Johnson's fantastic PhD work and supervised by myself and Sonal, is to create a platform that allows doctors to communicate about clinical tasks more easily. So instead of someone just bleeping 20 different jobs that aren't prioritized, there's a categorization here where jobs are assigned to the correct person on physiological parameters. So that drip that needs doing, there may be 5 drips that need doing in one shift. The junior doctor is sent down the line of picking the patient that needs that drip quickest. Improving access to information. People keep saying this afternoon about information. We all have, anyone not have a smartphone in this audience? Okay. 3 people, okay? 5 people. You know, 80–90% of our patients have access to these kind of technologies now. This is my own phone, okay? Hopefully this video will work. And this just shows you the kind of things I have on my phone. The antibiotic guidelines. Imperial was the first trust to develop guidelines, app-based. I would never prescribe a medication now without looking on my phone. This tells me what I should be prescribing very quickly within a couple of seconds. Matt's already introduced this resource about guidelines for the dying patient. At 3 a.m. in the morning, you do not want to be looking on the intranet for a policy document that will tell you how to manage the dying patient. Within seconds, you open your phone up and you can have a look. This is another CPSSQ funded project targeted at patients, led by Steph Russ, providing really salient guidelines to patients coming in for surgery about how they can avoid error. Simple instructions that no one thinks of telling patients. And these technologies, these pervasive technologies, I think open up fantastic opportunities to deliver information when people need it and in the right place. Some information about how you can prevent falls in hospitals. When do we ever tell patients about how they can prevent falls in hospitals? So that's my phone. That's not made up for this occasion. That is how I practice medicine now. And my conclusion is that these technologies, some of which I've described, could have a massive impact on patient safety. And I really think we should all be supporting them. So thank you for your time.
Thank you very much, Dominic. I think we're going to move straight on to our next speaker, who's going to be speaking against the motion that this House believes technology is the way forward. So with great pleasure, and once we're ready with the technology, we'll have Jed speaking. Thank you.
Okay. I'm going to start by actually agreeing with Dominic absolutely outright. We are way behind when it comes to technological advance in healthcare. And I think there's an important reason for that. When I was about 8 years old, my dad bought me a racing bike. And this bike had 3 gears. So for about a year among my friends, I was king of the hill. This was wonderful. And then a year later, a friend of mine got a racing bike. It had 5 gears. Now, I started to get a bit twitchy, but okay, I can live with that. A year down the line, another friend of mine for his birthday got a racing bike with 10 gears, with the little levers on the crossbar, the soft handlebars, the what was called GT brakes. They had no wires. It was unbelievable. It was almost magical. The soft saddle. This was Tour de France technology. And I wanted this. It wasn't long before, of course, I'm putting in a request for an upgrade. My parents, quite rightly, I think, just refused outright. But I remember at one point talking to my dad about this, and he said, look, you have a bicycle with 3 gears. If anything goes wrong with them, you have 3 problems. If you have a bicycle with 10 gears, if anything goes wrong with them, you have 10 problems. Now, I don't think he was absolutely right on this, but I think he was touching on something that runs to the core of technical and technological advance, which is this: its inherent capability to introduce layers of complexity and potentially confusion, which all too often are unnecessary. Almost all clinical processes in some way are dependent on technology, various systems and processes. Healthcare, however, does present a particular case. Many industries have been transformed by technology, but healthcare remains a hands-on activity. It requires dynamism, flexibility, the ability to think on your feet, but above all, caring and empathy. All of these things rest on good communication, good working practices. The human factors. Essentially, that's what healthcare boils down to. I'm going to take you back a couple of years to talk about particular technology that was introduced. And the reason I want to draw attention to this example is because I think it crystallizes pretty much what happens each time these advanced technologies get introduced into medicine. Some years ago, video conferencing systems were introduced, and the idea of telemedicine was born. And this was hailed as the future of medicine. Why? Because this was going to provide healthcare delivery to patients, irrespective of their geographical location, irrespective of their ability to actually go and see the doctor. This future of medicine lasted about 10 minutes. Because almost immediately clinical satisfaction with these systems was extremely low. It actually became a much more costly exercise than was originally envisaged. There were very high maintenance costs. These systems broke down frequently. Consultations often took longer because of the technological medium. But I think above all, the most important thing was that these technologies just didn't provide for the interactional workability that is a requisite of good quality healthcare. I was involved in a very small study, and I was presenting at a conference, and I was talking about the difficulty of picking up emotion in telemedicine consultations. I was looking at genetics consultations and the use of these systems. And somebody in the audience raised their hand and said, that's a problem with your pixelation. And as a sort of hardcore social scientist, I wasn't sure I was aware what pixelation was at the time. I'm not sure I was sort of fully... And he asked me to describe the system. So I described the system. And he said, you need the new system. That will take care of that. And I think that sort of gave me another message, which is the ability of technology to detract, to sort of distract us from the focus of what's really important. Trust me, on an advanced video conferencing system, it is still very difficult to pick up emotional cues that in the face-to-face encounter we would do almost instantaneously. Can technology improve patient safety? Potentially, yes. But just a sort of cursory perusal through the research literature, you will see that almost all of these technologies, some of the ones that Dominic's been talking about, designed to minimize error, also introduce other risks when it comes to healthcare delivery. That seems to me to be a kind of paradoxical situation, certainly from the point of view of healthcare delivery. But I wouldn't want to place that at the strategy of improving patient safety. More recently, a lot of attention has focused on computerized physician order entry systems. These systems are designed to reduce prescribing errors and guard against drug-adverse events, saving lives and saving money. But there are a whole host of problems associated with these new technologies. Primarily problems with the human-machine interface. In one study involving 261 participants, 261 healthcare professionals, 72% of that sample reported difficulties with pulling up prescribing information on the screen, partly due to the fact that to see all the patient's medications, you were looking at about 20 screens on an interface. Drop-down menus where medicines are listed in alphabetical order present the risk of confusing similar medications that look the same on the screen. Different medications rather that look the same on the screen. Also, these systems interfere with workload and work processes. And there's an interesting issue which is quite prominent in the literature now, which is this idea that these systems alter communication process because they generate the illusion of communication. The idea is that, well, I've entered the information on the system, therefore the right person will act on this appropriately at the right time. So there is a sense in which these systems actually switch off our situational awareness, again, something which is integral to good quality healthcare delivery. So, introducing new technologies will always compromise patient safety, simply because patient safety is built upon good human interaction between clinicians and clinicians themselves. And it's that simple. I mean, if you think about it, one of the, if not the early driver of the patient safety movement was not the recognition of technological failure in healthcare. It was a recognition of the simple fact that clinicians and patients were not really communicating well enough. I'll rest my case.
Thank Thank you very much to both of our speakers for a fantastic talk, both for and against. We're now going to take some questions from the floor. At the front here. Paul, just wait for the mic.
I'll wait for the mic. Dominic, you kind of gave a bit of a false choice at the beginning between education and training or technology. Now, there are many other ways to improve patient safety apart from those two broad choices that you gave. So I suggest to you, sir, that actually your technology argument is not as strong when set against the context of other things you can do, like changing systems, regulation, surveillance, etc.
Yes, although I would say the numbers speak for themselves. So the current systems that we're using in terms of trying to encourage patient safety, we're still getting patients with swabs and the wrong limb operated on. Now, there are sanctions against that. You could well find yourself up against the GMC if you do that. There's plenty of training, there's plenty of checklists to try and stop that. So I agree there's many strategies to try and enhance patient safety. I think the numbers speak for themselves. The data that Charles Vincent published a decade ago showing 10% of patients have some form of harm when they come into hospital. I don't think that's probably changed that much if we repeated that. And so I think there is a role for new strategies. And the example I gave of the car, I would say the road deaths are a quarter of what they were in the 1960s or 70s. There are many more people driving cars, just as there are many more episodes of care in our hospitals. The automobile industry have been effective at changing behavior. We haven't. And so I think the missing link is probably technology rather than other things.
Thank you. Anybody else?
I wonder what both of you think about some of the things I raised in telling my story, issues about patient involvement, failure to not involve patients, issues around patient safety culture, lack of transparency and openness, and therefore failure to learn and therefore to develop a new patient safety culture. So how does this fit into the technological debate either way?
I think Jed first.
I think, from my point of view, I think, going back to what I was saying earlier, the danger, I think, is for the potential of these systems to, in fact, increase the risk of these things happening again. Not so much. I mean, I think we're talking about the way in which these systems alter the dynamic of communication interaction between teams, between relevant groups. So, from my point of view, that wouldn't necessarily be a good thing. I don't think that is an advance in the right direction.
So I think what you're talking about is this form of kind of what is called information asymmetry. All the information and the power that you described from 17 years ago was in the hands of the clinician. Now I think we've moved on since then. I'm going to go into a clinic straight after here, see 15 patients, and all of those patients will receive the letter that I send to the GP. They will receive the same letter. So I do think things are improving, but I'll give you an example of a hospital that I think does this fantastically with technology. So if you go to the Mayo Clinic, I know it's the Mayo Clinic and they may have more resources than us. If you look at a video online of the Mayo Clinic that Apple have done for them, every patient at the Mayo Clinic has an app that they can go on to, and they can look at their own test results, they can look at when their upcoming appointments are, they can look at all correspondence about them. Nothing is kept secret. And I wonder if that would have changed what would have happened with you in terms of just having more access to information. If you'd seen a letter or the report from the investigations that your daughter had, that would have changed the whole kind of the way information was handled. And I think things are improving. I think technology will definitely enhance things further, and people will know their blood tests probably before their doctors, and they'll say, what are you going to do about my potassium level? And I wouldn't even know that the potassium level has come back yet. And that's, I think, what we should be moving towards, putting patients in control of information about them.
I think it's part of the story.
Yeah.
Okay, I think we've got time for one quick question.
Sorry, I don't intend to be terribly quick. The problem is not with lack of technology. The problem is with institutional inertia, with lack of communication, and with failure to learn. The NHS is not a learning organisation. There is not the system whereby reports are filed, the organisation learns from them, it changes structures or procedures, and it trains people in the new procedures. The difference within the NHS and other high safety organisations is that organisations such as rail, nuclear industry, oil exploration and drilling, and aviation have incorporated training in human factors throughout, and regular retraining in what in aviation is called crew resource management. The recent Human Factors Concordat mistakenly announced that human factors was ergonomics. They ignored fatigue, lighting, noise, communication, memory, mental modelling, personality types, air quality, situational awareness, authority gradients, decision-making processes, work overload or underload, state of arousal or stress, effects of people's concentration of events like money problems, moving house, divorce, bereavement. They said human factors is ergonomics. It's how people interact with machines. I respectfully suggest that no, it's not. The problem is higher up the chain with management, as Josephine found out, is with willful obstructiveness, willful failure to learn, willful blindness, and that goes all the way to the top. Dan Poulter had the nerve to say to Parliament, there is no evidence that having statutory minimum nursing levels makes a difference to standard of care. He ignores studies from both Victoria, state of Victoria and Australia.
Back that up, sir.
Okay, and Australia and California that both said that it resulted in increased recruitment, increased retention, heightened job satisfaction, and decreased turnover in staff, and therefore happier staff, and therefore patients better cared for. And that's nothing to do with technology.
Okay, Dominic?
I agree, as I said to Paul, there's multiple factors involved. My premise started here that often our intentions and our behaviour, there's a contrast there that we need to challenge, and technology can support our behaviour and lead to better outcomes. I'm certainly not saying it's the only solution. As I said, I don't believe that care should be delivered by robots. I believe humans are central to that. Human factors are very important, but technology and every aspect of our life is supportive, or can be supportive, or has the potential to be supportive, and I do think it does in healthcare too.
Thank you very much to both of our speakers for a very lively and topical debate. I'm now going to ask everybody to re-vote on the motion, and let's see who swung which direction. So this House believes that technology is the way forward for patient safety. All those who are now for the motion, hands up. Okay, definitely more. And all those who are against? I think it's a draw. I think we're going to have to call it a draw. Thank you very much, everybody. And I'm going to hand over to Dominic.